Doctor, my stimulants stopped working. Can I add bupropion? Can I combine dexamphetamine and methylphenidate? The patient is tolerant to the stimulant. Can I go up beyond the normal dose? My patient feels that methylphenidate does not give them the boost. They feel the boost with dexamphetamine. Can I combine the two? These are questions asked by both doctors and patients alike. In this video, I'm going to take you through the understanding of ADHD and where stimulants fit in the management of ADHD. Because the answer for the effective management of ADHD does not simply lie in the prescribing of stimulants. I'm Dr. Sanil Rege, consultant psychiatrist, and welcome to Psychiatry Simplified, the channel where we cover all things related to psychiatry, neuroscience, and mental health. So if that's your thing, don't forget to hit the subscribe button. So without further ado, let's jump straight into the video and answer a pressing question that many face in their ADHD journey. What should I do when my stimulants stop working? So let's uncover the neuroscience behind ADHD management and explore effective solutions. And the way we will do this is through 10 essential points that all clinicians and patients should know when it comes to effective diagnosis and management of ADHD. ADHD management is complex and multifaceted. In fact, it's one of the most paradoxically complex conditions. I often say in teaching that there are no true experts in ADHD. Since to be an expert in ADHD, one has to recognize its manifestations across the lifespan and its relationship with other psychiatric disorders. Thus, a true expert in ADHD is an expert across psychiatry as a whole. So with that in mind, let's look at the 10 essential points. Number 1, ADHD is a heterogeneous condition. And what I mean by heterogeneous is that the presentation of ADHD differs from individual to individual. There are permutations and combinations between the symptoms related to prefrontal cortex, the striatum, and the emotional arousal areas. There are differences with additional comorbidities, as we'll see. Thus, no individual is alike when it comes to ADHD. Thus, when the stimulant stops working, it becomes important to delve deeper into understanding the heterogeneity, the unique individual factors that may be playing a part in preventing the individual responding well to this stimulant. 2. The importance of treating multiple domains. You see, when we think about stimulants, we essentially consider agents such as methylphenidate and dexamphetamine, which block the dopamine and noradrenaline transporters to increase their levels within the synaptic cleft. Now, we've got a range of videos on ADHD and ADHD pharmacology. So don't forget to check out the differences between dexamphetamine and methylphenidate to delve deeper into the pharmacology. Now, in order to understand why the patient hasn't responded to the stimulant, we need to understand the domains of ADHD. So what are these domains? First, cognition. This includes executive function. Second, activity dimensions, hyperactivity, but also agitation or hypoactivity, such as lack of motivation. Third, reward sensitivity. This is the response to reward that is different in individuals with ADHD versus neurotypical individuals. We know that the reward dimensions include dopaminergic pathways. Essentially, the response to reward is blunted in individuals with ADHD. Thus, what the stimulants are trying to do is to move the individual from a paradigm where they're operating within an immediate gratification paradigm towards the delayed gratification paradigm. By doing this, individuals are able to sustain their attention with relation to tasks, but are also motivated to engage in a range of tasks waiting for the reward in the future, the delayed gratification. Now, besides these 3 dimensions, there are 3 additional crucial dimensions that are often overlooked. 1, behavioral activation, which is really the get up and go. It's linked to motivation, but we know that the prefrontal cortex and the striatal pathways, we know that they mediate both the hedonic drive and the subsequent motivation. So behavioral activation here is an important component. Next, we also have behavioral inhibition. This is about emotional regulation and impulse control. When this is affected, we see symptoms such as emotional dysregulation, but also a range of impulse dysregulation disorders. Hyperactivity also is part of this domain in addition to the activity dimension. And finally, the fight and flight response. You see, individuals with ADHD may have a heightened amygdala, and this occurs, for example, in individuals that may have experienced significant trauma, or in individuals with comorbid autism spectrum disorder, because we know that individuals with autism spectrum disorder tend to have a heightened amygdala, which often results in a heightening of emotional responses. Now, when we add gender differences here, we know that female ADHD is linked to an emotional arousal model, which is different from males, which is linked to a developmental deviation model. Thus, when we combine ADHD with the female gender, we are predominantly looking at a heightened fight and flight response or a heightened emotional arousal response. In such cases, only working along the paradigm of a stimulant may actually worsen things. Many a time, individuals may experience benefits in the first few months, but then they come back to you and say the stimulant stopped working. At this point, it's not really that the stimulant stopped working. It could have, but one's got to move away and look at these domains and ask ourselves which of these domains have been targeted, which of the domains are acting as barriers to improvement. The third point, the prefrontal cortex and the Goldilocks effect. You see, the prefrontal cortex is the seat of executive function and the top-down modulation to control impulses and for optimal emotional regulation. However, the prefrontal cortex operates on a Goldilocks effect. And what do I mean by that? The Goldilocks effect essentially is the porridge, not too hot, not too cold, just right. The prefrontal cortex as well operates on the same principle. Too little dopamine and noradrenaline, and there is executive dysfunction, difficulties with attention, concentration, emotional regulation, etc. The symptoms that we see as part of ADHD. Too much, and here this can contribute to stimulus-bound responses, cognitive rigidity, and in adolescence, repetitive movements such as tics. Thus, for a clinician, it is crucial to optimize the stimulant doses to ensure the prefrontal cortex functioning is balanced. And we can identify this through clinical symptoms. For example, in some cases, when the stimulant dose goes too high, patients can talk about the thoughts being repetitive or intrusive, or that their executive function is actually worsened, that they can't focus on the task. This is where the dial shifted towards the other side, a stimulus-bound response where the individual now is heightened. Number 4, comorbidity. ADHD is one of the most comorbid conditions. Comorbidities include sleep disorders, autism spectrum disorder, and in adults can include depression, bipolarity, substance use disorders. In adolescents can include sleep breathing disorders, tonsil and adenoid enlargement. In females, autoimmune thyroiditis or iron deficiency anemia. If these comorbidities aren't picked up and one is simply focusing on stimulants, essentially what happens is that the stimulant doses can keep going up, affecting prefrontal cortex functioning, whilst there is a completely different process that is ongoing and unaddressed. This sets up a cascade towards further worsening. For example, iron is a cofactor in the production of dopamine. It is essential for the functioning of tyrosine hydroxylase, the enzyme that converts tyrosine into dopa, which then converts to dopamine. If you're a clinician and you're interested in really delving deeper into the understanding of ADHD, connecting the symptoms, phenomenology, and comorbidities, neuroscience, optimal psychological strategies, and learning through case studies, then check out the Academy. We've received excellent feedback, and of course, the important thing is with all our courses, we connect to other courses, such as ADHD and PMDD overlap, ADHD and perimenopausal disorder overlap, ADHD and chronic fatigue syndrome overlap. Thus, as I mentioned right at the start, in order to be an expert in ADHD is to be an expert in psychiatry across the whole. So don't forget to check out academy.psychscene.com for a really effective way of learning in psychiatry. Let's get back to the video. Number 5, recognize the complexity in ADHD. ADHD is like an iceberg. What we see at the top of the iceberg is quite different from what might be lurking beneath. What lurks beneath may be comorbidities or other factors that prevent the optimum response to the medications that you're prescribing. Hence, it is important to consider a comprehensive formulation in the assessment that then leads to an individualized management plan. The formulation consists of bio-psycho-socio-cultural, spiritual, diet, and lifestyle factors. For example, a sleep disorder can significantly impair any response to a stimulant. Sure, they may respond to the start. In many cases, individuals improve. Their sleep improves as well. However, I'm talking about situations where there is breakthrough or the initial response isn't maintained, because ultimately ADHD is a lifespan condition. So the response isn't just about what happens in the first month or 6 months. It's about ensuring the individual meets their long-term goals. And that brings me to point number 6, the frame of ADHD treatment. You see, the frame of ADHD treatment is way more important than the actual pharmacological treatment. And what I mean by the frame is a long-term approach. The choices of medications that we need to consider should be with a view towards the long term. And the goals that we want to target include clinical goals, considering all the domains that I mentioned, personal goals, the goals outlined by the patient, and recovery goals. Recovery goals include financial aspects, accommodation aspects, relationship aspects, and vocational aspects. Number 7, ADHD management isn't just about stimulants. Consider the non-stimulant strategies as well. In many cases, individuals need a buffer. For example, females often can have heightened responses to stimulants. Dexamphetamine a lot more than methylphenidate due to the serotonergic potentiation that's present. In such cases, they often require a buffer, either a mood stabilizer and or medication such as clonidine. If comorbidities are present, consider addressing the comorbidities at the same time. For example, addressing the medical conditions. But if insomnia is present, it becomes important to understand the nature of insomnia. If REM hyperarousal is present, which is something I've covered in the video that differentiates anxiety from hyperarousal versus agitation, then the approach needs to be quite different. We can't just consider a stimulant because the stimulant could worsen things over the long term. You see, the risk of switching, for example, a bipolar disorder switch, or even the most extreme cases of psychosis, usually occur when many of these comorbidities or individual factors are not taken into account. For example, a genetic vulnerability towards psychosis, or significant sleep difficulties. For example, we know that the presence of anxiety is a risk factor for stimulant-induced bipolarity. So therefore, consider pharmacological approaches beyond stimulants, but also implement non-pharmacological strategies, which could include strategies such as sleep hygiene or otherwise, depending on what's been identified. Number 8, understand the differences between phasic dopamine and tonic dopamine. You see, phasic dopamine refers to the phasic bursts, high spikes of dopamine that activate the D1 receptors that are responsible for the early phases to kickstart learning, motivation, drive, etc. Tonic dopamine is the more sustained form of dopamine that is necessary for movement, sustained attention, sustained motivation, and the shift from immediate gratification to delayed gratification. You see, in treatment, too much phasic dopamine is unhelpful. Why? Because it moves the individual towards the right-hand side of the curve, resulting in cognitive rigidity and stimulus-bound responses. It mimics a substance use paradigm. Thus, consider an optimal balance between phasic and tonic dopamine. And the way we do this is to consider longer-acting agents, because the aim of ADHD treatment is to ensure that the treatment lasts throughout the day, ensuring that the individual is able to fall asleep, which means that the prefrontal cortex is able to reduce arousal, helping them fall asleep. In many cases, the stimulant may not last as long, in which case it's not just about dose adjustments, but rather prolonging the effects of the stimulant, and there are a range of strategies for this. Number 9, avoid the cycle of sensitization and desensitization with stimulants. This is one of the key reasons for non-response, non-adherence to stimulants, and side effects. This is also one of the reasons that results in what we call tolerance or tachyphylaxis. But the reason why this happens is not just because the dose isn't adequate. And the answer here isn't just about increasing the dose, because when you do increase the dose, sure, you get a short-term response. But remember, ADHD is about the long-term, the lifespan approach. The problem with long-term phasic dopamine is a diminished sense of reward over time. This is a very similar phenomenon that occurs with other substances of misuse that result in repeated phasic dopamine. And finally, number 10, the optimal functioning of the prefrontal cortex, striatal, and mesolimbic pathways. Remember, because it's a lifespan approach, the prefrontal cortex, the striatum, and the mesolimbic pathways will change over the lifetime. And this may require modulation of medication and non-medication strategies. A key aspect that's often missed is the mesolimbic pathway. The mesolimbic pathway mediates arousal and reward. When this involves hyperarousal, it's one of the key factors that prevents the stimulants from working optimally. It's also one of the key factors that results in worsening when stimulants are prescribed. So therefore, look after this mesolimbic pathway in your treatment. And when it comes to the striatal pathways, the main aim is to have an optimal balance between the goal-directed part, the dorsomedial striatum, and the habit part, the dorsolateral striatum. Here, we want adequate goal-directed activities, and through repetition, many of these goal-directed activities become habits. But if we have too much phasic dopamine, the individual starts operating predominantly on the habit pathway. This is exactly the pathophysiology of obsessive compulsive disorder, and you might recognize why there is now an overlap between ADHD and OCD. Ultimately, it comes down to the D1, D2 balance, the phasic dopamine and the tonic dopamine. Thus, pharmacological modulation is a crucial part of ADHD treatment, but it's not just about stimulants. So to summarize, I hope that this video has given you a broader understanding of what ADHD as a construct is. It may sound simple when it comes to symptoms and checklists. However, that's not how the brain operates. And as humans, we change over the lifespan. The prefrontal cortex in adolescent years is developing. In adult years, the prefrontal cortex will have developed. Thus, we've got to individualize treatment for these two phases. If you liked the video, don't forget to leave us a like. And of course, don't forget to subscribe to our channel. A big thank you to all of you for supporting this channel. We really appreciate it. I look forward to seeing you in another video soon. Until then, stay curious. Bye-bye.